Hello everyone. Today's lecture is going to consist of an investigation into the histology and a little bit of the physiology of very important glands for the oral cavity, and that's the salivary glands. You'll recall from our lecture last term on epithelium that epithelium is subcategorized into two large categories, and that's our lining epithelium and then our glandular epithelium. Thus, the parenchymal cells of glandular tissues, for example, salivary glands, are composed of epithelial cells. So for today's lecture, we're going to be looking quite closely at the salivary glands themselves and looking at the histological appearance of the acini, so the parenchymal cells that make up the acini of the gland, and also the ductal system that drains the saliva from these glands. We're also going to investigate a little bit of the function of the salivary glands and look a little closer at saliva and some of the roles that saliva plays in the oral cavity. The development of salivary glands begins very early in embryonic life, so roughly around 4 to 6 weeks. And this development is dependent on the epithelium being stimulated by the ectomesenchymal tissue. Now, interestingly, this same interaction is quite important in tooth development as well, as we'll learn later on in the term. Salivary glands continue to develop until we are roughly 2 years of age. Here we have a histological image of a fetus at 12 weeks of age, demonstrating, first off, highlighted by the blue arrow, simply lining epithelium. Underneath the lining epithelium, we have mesenchymal or connective tissue. Within this connective tissue, highlighted by the black arrow, we can see glandular epithelium beginning to develop that will eventually give rise to a salivary gland. And then interestingly, highlighted by the red arrow and a topic we will be discussing later in the term, we can see a developing tooth follicle. When we view a slightly more mature fetus at 17 weeks, we can see that the glandular epithelial cells are starting to become more organized and giving rise to a lobular structure. This lobular structure will eventually make up the salivary gland. Some of the epithelial cells will begin to differentiate and form the ductal network of the salivary gland, while other epithelial cells are going to give rise to the glandular cells that will produce the saliva. In the mature salivary gland, the glandular epithelial cells are going to produce acini. The acini are going to be associated with a network of ducts. Together, the acini and these tubules form what we call a secretory unit. These secretory units combine to form a lobule. Multiple lobules together give rise to a lobe, and multiple lobes will then create the mature salivary gland. These lobes will have a network of connective tissue septi that hold the entire gland together. And recall again from last term that we learned about two different types of glands that we have in our body. That's the endocrine and exocrine glands. Salivary glands are indeed an example of exocrine glands. So recall that these particular glands release their contents via ducts to either other body cavities or to our body surface. You will recall from last term that we learned that there are 3 different mechanisms for exocrine glands to release their contents. The most common is the merocrine gland, which a salivary gland is an example. So this is when vesicles will fuse with the apical pole of the glandular cell and release its contents into the lumen of the acini. This is, of course, termed exocytoses, which you're all extremely familiar with. And the other two mechanisms include occurs in halocrine glands. So this is when cells will accumulate their material and begin to enlarge, and then the cell will begin to be disrupted and disintegrate, releasing its contents into the gland lumen. This is seen in sebaceous glands. So recall, sebaceous glands are associated most typically with hair follicles in the skin. And then lastly, we have apocrine secretion, and this is when products will accumulate in the apical pole of the glandular cell, and then a portion of the cell will actually pinch off into the lumen of the gland. This form of secretion is seen in mammary glands. And one final concept to bring back from last term was the classification of exocrine glands based on the type of secretory unit that we're dealing with, meaning its shape. Is it tubular or is it round or alveolar? And then also the ductal structures. Are they a simple tube or a simple branched tube, or does it have a much more complex branching structure? And I really don't need you to memorize these various different shapes. I don't think it's all that critical. It is very difficult to appreciate the different branching structures of the tubes when we look at the histology. So I don't think we have to overemphasize this concept. Salivary glands in the oral cavity are broken up into major and minor glands. So the major glands include the parotid gland, the submandibular gland, and the sublingual gland, while the minor glands are distributed throughout the oral cavity, with the exception of the gingiva, the majority of the tongue dorsum, as well as the anterior hard palate. And looking first at the parotid gland, this is just a reminder of a nice schematic image of the location of the parotid gland, just anterior to the external auditory meatus. When we palpate the parotid gland, we're obviously in front of the ear. It can actually be quite difficult to really appreciate the parotid gland unless it were to be enlarged or have some type of pathoses associated with it. I'm certain you've already learnt this concept in gross anatomy, but do recall that the parotid gland is permeated by our very important nerve, so that's cranial nerve 7, our facial nerve, but the facial nerve does not supply the parotid gland. The parotid gland is drained by a fairly large duct, and this is either called the parotid duct or has also been known as Stenson's duct. This duct is roughly 4 to 7 centimeters in length. It exits the gland along the anterior edge and traverses our masseter muscle. It penetrates the buccal fat pad and the buccinator muscle to open up into the oral cavity within the buccal mucosa. This area is roughly adjacent to the second maxillary molar. Intraorally, when we look at the buccal mucosa, the opening of the parotid duct sometimes is very flat and difficult to see, and then other times it actually has a prominent papillae around the ductal opening. If you were to press on the parotid gland, so milk the parotid gland, you often can express some saliva through the duct opening, and that can at times help you locate where the salivary duct opening, where Stenson's duct is actually located. The parotid gland is one of the largest of the major glands. It is a 100% serous gland, meaning that it produces a very watery saliva, so it has a low quantity of mucins within it. Another example of a serous gland that we've already had a little bit of peek of during our tongue lab is the serous glands of von Ebner. So remember, those glands secrete its secretions into the troughs around the circumvallate papillae. Now, the parotid gland provides roughly 25% of our saliva when we're just sitting at rest. When we are stimulated, in particular by eating or chewing, the salivary gland will increase its function to supply roughly 50% of our saliva. Again, the facial nerve, so cranial nerve 7, courses through this gland. The facial nerve actually separates the gland into a superficial as well as a deep lobe. Interestingly, the superficial lobe is one of the more common locations for the uncommon tumor, salivary gland tumors. The gland itself is innervated by the glossopharyngeal nerve, so this is cranial nerve 9. Its blood supply is via the external carotid artery, and it's drained via the retromandibular veins. The parotid gland itself may also contain several lymph nodes, and this number can vary from 1 or 2 up to roughly 24 lymph nodes within the gland itself. These lymph nodes will drain the ear, the temporal region of the scalp, the lateral face, the eyelids, as well as the conjunctiva. So if someone were to be having an infection in any of those areas, in an extraoral examination, we might actually palpate an enlarged lymph node within the parotid gland due to the infection in one of those distant locations. And then moving on to the submandibular gland. So this, of course, is located in the floor of the mouth towards the posterior aspect and wraps around the mylohyoid muscle. This particular gland can be palpated, particularly with an extra and intraoral approach from both sides. You're able to palpate quite nicely the submandibular gland in patients. This gland is drained by a fairly large duct. This would be Wharton's duct or the submandibular duct, and it's roughly 5 centimeters in length. It drains into the anterior floor of the mouth via sublingual caruncles or sublingual duct openings. So either terminology is certainly acceptable. The submandibular gland is the second largest of our major glands and provides roughly 50 to 60% of our total saliva. The submandibular gland is composed of both serous as well as mucinous acini. So it's considered a seromucous gland. Its secretions are thus much stickier than what we would receive from the parotid gland. The submandibular gland has its blood supply via the sublingual and submental arteries, and it's drained by the anterior facial vein. It is innervated by the facial nerve, so cranial nerve 7. And here's a nice image of the submandibular duct coursing through the floor of the mouth. And then the last and smallest of the major glands is the sublingual gland. So this is located more anteriorly in the floor of the mouth, superior to the mylohyoid muscle. This gland can actually be quite difficult to appreciate upon palpation. This gland is drained via the sublingual duct, which actually empties into the submandibular duct. And it also has some very small little ducts that are going to drain the gland directly into the floor of the mouth, and these ducts are referred to as the ducts of Ravinus. And similar to the submandibular gland, the sublingual gland is composed of both serous as well as mucinous acini, but it does have a higher content of mucus cells in comparison to the submandibular gland. Its blood supply is also via the sublingual and submental arteries, and it is drained by the sublingual vein. And again, like the submandibular gland, it is innervated by cranial nerve 7. And here's a very nice gross image of the submandibular duct, again in the floor of the mouth. Very small folds of tissue will contain the ducts of Ravenous, so the small little ducts that will be draining the sublingual gland directly. And then we have the sublingual caruncles, which is going to empty the submandibular duct, which again is fed also by the sublingual duct. As I already alluded to, the submandibular gland can be nicely palpated by a bimanual approach. So one finger in and under the tongue and one finger under the chin, and you can palpate the gland between your two fingers. Interestingly, there's a lot of variability in gland size from one side to the other in a given patient. And I've just included here a nice summary diagram of the major salivary glands from your textbook figure 16-1. And then moving to the other type of salivary gland we have in the oral cavity, and these are the minor salivary glands. We have a large portion of minor salivary glands, roughly 600 to 1,000, and these represent discrete aggregates of salivary gland tissue located within the submucosa throughout the oral cavity. Minor glands again are not found in the gingiva, anterior hard palate, and the majority of the tongue dorsum. So the one exception would be the serous glands of von Ebner. Salivary glands typically are mucus glands, and these serous glands of von Ebner are our only exception. Minor salivary glands account for roughly 10% of our salivary flow. In order to appreciate the minor salivary glands, if you were to squeeze your lower lip very gently, you'll appreciate a nodularity to the lower lip, and that's your minor salivary glands studding the submucosa in this region. Sometimes when the minor glands are quite prominent, you'll see a very bumpy surface texture to the labial mucosa in patients' mouths. Okay, so now let's take a closer look at the ultrastructure of the salivary glands. So we're going to be perusing the different acini and ductal structures that are going to give rise to those secretory units of the salivary glands. So as we learn about the ultrastructure of the salivary glands, I'm going to use the submandibular gland as a good example, as it has both serous acini as well as mucus acini as well. Now this is a schematic diagram from figure 16-2 from your textbook, and we're going to break it apart into smaller pieces. So within the submandibular gland, we're going to find acini that are composed purely of serous cells. So these are the serous acini. We're going to find acini composed purely of mucus cells. And these acini, at least in the submandibular gland, tend to have a more tubular shape to them versus a round shape or alveolar shape. And then we're also going to find a combination of mucus as well as serous cells together, giving rise to an acini. So let's talk first about the serous cells, or the serous acini specifically. The serous acini are composed of very polygonal shaped serous cells. They have a round nucleus that's located towards the basal pole of the cell, and the apical pole of the cell is studded with protein-containing vesicles that are going to be secreted into the lumen of the serous acini. And this lumen is fairly small, as you can see highlighted by the red arrow in this slide. Studying the surface of the serous acini, we will find myoepithelial cells, and this is fairly common to any of the acini units within salivary glands, and we'll review their function in a moment. When we view the ultrastructure of the serous cell, this is figure 11-11 from your textbook, you can see that the large, round, open-faced nucleus is actively producing mRNA to give rise to protein production. There's a complex network of Golgi body and endoplasmic reticulum that's going to package all of this protein into secretory vesicles that we can see in the apical region, and then via exocytosis they will be released into the lumen of the serous acini. This entire process is stimulated by the autonomic nervous system. Figure 4-24 from your textbook is an EM view of a serous cell, and you can see the extensive network of Golgi apparatus around the nucleus, being a very euchromatic nucleus actively producing mRNA again, and the gray round structures representing the secretory granules that are going to be secreted via exocytosis into that small lumen labeled with an L. Here we have a medium power view of the parotid gland. Recalling, of course, it's composed of 100% serous acini, so it picks up a lot of stain. Here we have a higher power view of multiple serous acini. So the serous cells themselves are quite dark stained because of the proteins within the secretory vesicles picking up a lot of the stain. So they appear quite stippled in texture towards the apical pole, and we can see that open-faced, basally located nucleus. And interestingly, it's often difficult to even appreciate a lumen within some of these serous acini. And this is one because the lumen is quite small, and due to artifact in sectioning through a gland, sometimes we're not actually seeing the lumen at all. On the right-hand side of the screen, this becomes quite a confusing image of multiple serous acini as they're all squished together, so it's even difficult to appreciate one acini from another at times. On the left-hand side, we have a EM shot of multiple serous acini that allows us to nicely appreciate all of those secretory granules that exist within the cytoplasm. And in this particular EM shot, on the lower aspect of the diagram, and highlighted by the blue arrow, is one of the ducts that's going to be draining this particular serous acini. Now let's move on to the mucous acini or mucous tubules. We often term them mucous tubules just based on the fact that they have a much more tubular structure than the serous acini, but nothing wrong in calling them mucous acini either. The mucous cells have a slightly different ultrastructure in comparison to serous cells in that their nucleus is quite flattened and pressed towards the apical pole. They don't have it as nearly as extensive of a Golgi apparatus, and the cytoplasm is jam-packed full of secretory vesicles, but these secretory vesicles contain mucin. This mucin doesn't pick up near the amount of stain that the secretory vesicles do in serous cells. Hence, they have a much lighter, light pink, if anything, appearance in comparison to the serous cells. And figure 11-15 from your text is a nice EM shot of a mucous cell, and you can appreciate all of the quite extensive, large secretory vesicles containing mucins and some various Golgi body in and around the basally positioned and quite squished, flattened nucleus. The last type of acini is the mixed acini, which is composed of both mucous cells as well as serous cells. And these serous cells tend to have a more crescent shape, and they are perched on top of the mucous cells. So we coin these the serous demilunes. And here we have a histological image of several mixed acini with the very pale staining mucus cells labeled with an M and the crescent-shaped serous demilunes perched over top of them, highlighted by the black arrow. And interestingly, in this image is a nice longitudinal section of a duct that will be draining this particular salivary gland lobule. And we'll talk about ducts a little more in a moment. This EM image of a serous demilune is a great comparison between the mucus cells and the serous cells. You can see the marked difference between the nature of the secretory granules and the prominent nucleus that we see within the serous cells in comparison to the mucus cells. Figure 16-5 from your textbook is a great comparison between the submandibular gland as well as the sublingual gland. So starting on the right-hand side of the screen with the sublingual gland, recall that again it's composed of both serous as well as mucus cells, but the mucus cells certainly predominate. So here encircled on this picture is a mucus acini, and of course also we can call a mucus tubule given its more tubular structure. And then on the left-hand side of the screen in the submandibular gland, which again is a mixed gland with both serous and mucus cells, we can see a pure serous gland with its very dark staining, granular appearing cytoplasm within the serous cells making up the serous acini, and in comparison to our mixed acini with the serous demilunes perched over top of the more tubular mucus cells. So bringing back again the schematic diagram that we started, so we've essentially reviewed the serous cells and these giving rise to, of course, the serous acini in comparison to the mucus acini or the mucus tubules, and then the mixed acini being composed of the serous demilunes with the mucus tubules. And now let's briefly look at the myoepithelial cells that stud the surface of the acini. And in this example, we have myoepithelial cells studding the surface of the serous acini. If I bring back the ultrastructure picture of the mixed acini that we've already viewed, you can see circled in yellow here is a very small cell studding the surface of this particular acini, and this is the myoepithelial cell. Not only are myoepithelial cells located around the acini within the salivary glands, but they're also found around the intercalated ducts. So we'll talk about the ductal systems momentarily. These myoepithelial cells play a very important role in promoting salivary secretions. They also aid the acinar cells to maintain their appropriate polarity, meaning the basal pole and apical pole are located where they should be. Myoepithelial cells are thought to have some tumor suppressor type activity as well. So they can be linked in with a lot of different neoplasms that we can see in salivary glands. In order to actively participate in salivary secretion, the myoepithelial cells have a stellate shaped and they are plastered on top of the acini and they're able to contract. So they have a small amount of actin and myosin fibers within their cytoplasm, giving them a contractile ability. This is a nice image on the left-hand side of the screen of the myoepithelial cells with their stellate structure plastered over top of the acini of a given gland. Figure 4-26 from your textbook I like the small insert labeled B, where the myoepithelial cell has been specially stained and is highlighted in brown, as we can see it surrounding and embracing the secretory cells making up this acini. So let's move now into the discussion about the ductal systems that exist within salivary glands. So we're going to start first with the intercalated ducts. So these are the ducts that are going to immediately drain a given acini. The intercalated ducts are actually thought to contain some of our undifferentiated salivary gland cells or stem cells that will give rise to new glandular cells. The intercalated ducts are composed of simple cuboidal epithelial cells, so that means only one layer thick. They're fairly short, and here we have a nice histological image, figure 11-23 from your textbook, that demonstrates in longitudinal section the intercalated duct. And here we have in this image a intercalated duct in cross section, so forming a nice circular structure lined by cuboidal epithelial cells with quite pink or eosinophilic cytoplasm and a large centrally located nucleus. The intercalated ducts will then join together and give rise to the striated duct. The striated ducts are also composed of one cell in thickness, but these cells have a larger, more columnar appearance in comparison to the intercalated ducts, and they have much more cytoplasm. The nucleus, again, is centrally located, and the cytoplasm has a very striated appearance, almost like a hairy-like appearance to it. The reason for this unique appearance to the cytoplasm within the striated duct cell is because of the fact that the basolateral membrane is actually extensively infolded. And within the cytoplasm in these infoldings is a high quantity of mitochondria. This particular architecture is quite important for modifying saliva. And bringing back a portion of figure 16-3 from your textbook, this is a great image of multiple serous acini with a striated duct sitting amongst them. You can easily appreciate the infoldings on the basolateral membrane of the striated duct cells, giving rise to that very sort of hairy-like appearance. This is a very nice histological example, again, of the parotid gland that depicts the comparison between the intercalated duct in comparison to the striated duct. So you can see marked difference in size of the ducts, viewed here, of course, in cross-section, and quite a distinct difference in the appearance of the cytoplasm as well. The primary function of the striated ducts is to create a hypotonic saliva. So it's responsible for resorption of cations via pumps. These pumps require a lot of energy, and that's why we have this increased quantity of mitochondria sitting within the basolateral membrane of the ductal cells. So let's walk through this process fairly slowly. So the acinar cells are best to consider them a salt secretor. So they're going to be secreting sodium, they're going to be secreting chloride as well, and this is going to pull water from the cells into the lumen of the acini. This creates an overall isotonic or even maybe slightly hypertonic saliva. This saliva will then flow through the intercalated ducts and into the striated ducts, where we will have a creation of a hypotonic saliva. In order to accomplish this, The ductal cells will resorb sodium, they will resorb chlorine ions, and they will excrete bicarbonate. So think of them as bicarbonate secretors, as well as some potassium ions as well. And that will generate a hypotonic saliva, which will then enter into the rest of the ductal system. This electrolyte resorption is controlled by the autonomic nervous system and also via a mineral corticosteroid known as aldosterone. And this is produced in the adrenal gland. The striated ducts will then coalesce together and give rise to an excretory duct. The excretory duct is a bilayered duct, and it is located between the salivary gland lobules. So it is a interlobular duct, and this excretory duct will then join with the epithelial surface to excrete the salivary contents. Both the striated duct and the intercalated ducts are within the lobule proper, so they are considered an intralobular duct. Bringing back again another slide we've already seen, figure 11-5 of a minor salivary gland. You can see highlighted by the arrows the interlobular ducts, so the excretory ducts located within the connective tissue septi outside of a given lobe. The ductal system of the submandibular gland is demonstrated nicely by a cyalograph image. So here you can see the fine network of very fine ducts coalescing together and giving rise to the excretory duct that then will exit the submandibular gland. The excretory duct is composed of stratified cuboidal epithelium. So again, it's one of our rare examples of stratified cuboidal epithelium. In this case, we often see the more basal cell having a nucleus compressed towards the basal pole, and the more apical cell having a more centrally located nucleus. But as you can appreciate in this image, it's very hard to distinguish cell membranes between the two given cells making up this duct. Although this image is slightly darkly stained, it does depict a very nice example of the excretory duct with saliva sitting within it as it sits within a connective tissue septi between salivary gland lobules. Now coming back around to the minor salivary glands, so essentially they are again purely composed of mucus acini, with the only exception being our serous glands of von Ebner. They have a much less developed ductal system than the major glands. We have some sort of poorly developed intercalated ducts with virtually no striated ducts recognized within the minor salivary glands. And the interlobular ducts will open up right into the oral mucosa. So we don't see extremely well developed excretory ducts within these glands. And here's a nice low power image, stained, mind you, with a slightly different stain, but it does nicely highlight the very short excretory duct leading to the surface mucosa from a minor salivary gland. So if we put this all together, you can really think of a minor salivary gland like a tree. So the leaves of the tree are essentially the acini. The acini may be serous, they may be mucus, or they may be a mixed acini. They then are going to be drained by the first small branches on the tree being the intercalated ducts. The intercalated ducts will join together and give rise to striated ducts, which will then join together and form the excretory ducts that are located between the lobes and exiting the salivary gland and then to fuse with the stratified squamous epithelium of the surface mucosa, where it will then excrete its saliva. The main function of this gland is to secrete both proteins and mucins as well as water. And this action is all assisted by the contraction of the myoepithelial cells studding the acini and the intercalated ducts. Saliva is an extremely important fluid that we find in the oral cavity. Saliva is composed of water. It has various electrolytes, a myriad of secretory proteins. It also has some immunoglobulins, in particular IgA. And then we also have various other components, including glucose, various amino acids, urea, some fat, and some growth factors, and even a bit of albumin may be found within the saliva. We have essentially three types of saliva that come into our mouth. We first have mixed saliva. So this is coming from our mixed glands. So the submandibular and sublingual gland are going to produce a slightly sticky saliva due to both its protein and mucin content, with the sublingual gland secreting a slightly more mucousy containing saliva. And then we have our pure mucous saliva, so this is our viscous saliva that's secreted from the minor glands. So this is very rich in mucin with minimal protein. And then lastly, we have our much watery saliva. The watery saliva is coming, the majority of which is coming from the parotid glands. This particular saliva has a lot of water and is quite rich in amylase. Amylase helps to break down starches. And then from the von Ebner glands, so the serous glands of von Ebner located along the circumvallate papillae, we have also a watery saliva, and this one tends to be a little bit richer in lipase, which helps break down lipids. So both of these salivas do aid in the beginning of digestion within the oral cavity. In general, we produce quite a lot of saliva in a given day, with roughly 0.5 liters being produced. Our unstimulated whole saliva rate ranges from about 0.2 to 0.4 milliliters per minute. And then once it becomes stimulated, it increases quite markedly to a range of 4.5 milliliters in 5 minutes. In general, our stimulated saliva, the increase in salivary flow is due to the contributions from the parotid gland. Saliva has several important functions, including protection, buffering capacity, maintenance of tooth integrity. It has antimicrobial components, it aids in digestion, and it's also very important for taste transmission, as we've already learned. In order to protect us, the saliva carries out a couple of different roles. First off, it helps lubricate our tissues, and this is essentially so our tissues don't stick together at all. They're able to nicely move past each other, and also the soft tissues do not stick to the teeth. So this helps protect our tissues from trauma. It also helps concentrate minerals around the teeth proper, which contributes to remineralization of the teeth. And it also is, because of its volume, acts to clear bacteria as well as debris within the oral cavity. The majority of the buffering capacity of the saliva is due to the bicarbonate content, but also some of the more basic salivary proteins and phosphate as well help contribute to a pH of roughly 6.7 to 7.4. And the importance of maintaining the pH in this range is so that, one, our teeth are not demineralized, and it also helps neutralize any acids that we do intake into the oral cavity. Ammonia and urea are also produced by bacterial digestion of salivary proteins. So this will also contribute to an increase in pH. Not only will the maintenance of an appropriate pH maintain tooth integrity, but the saliva will also be supersaturated in calcium and phosphate due to particular binding proteins within the saliva, as well as containing fluoride ions. And these will all help in remineralization of the enamel. It's important, of course, in post-eruptive maturation of the enamel, and, of course, again, remineralization of incipient carious lesions. The antimicrobial effect of saliva is mainly carried out by the various antimicrobial proteins that are secreted. I'm not asking you to memorize all these different proteins, but just know that they are present. And we do have an immunoglobulin, in particular IgA, in our saliva, which will help mediate the cell-mediated portion of our immune system. And we also have just even the barrier effect of the mucins that are bound to our soft tissues will help decrease the ability of bacteria and other organisms to penetrate into the tissue. Our saliva will also aid in digestion. We already talked about the secretion of amylase and lipase, which are both going to initiate the digestion of carbohydrates as well as fats. The saliva itself will also help in the swallowing process in that it will moisten the bolus of food as we're engaging in chewing and forming a bolus to then swallow. And there's even a particular R binder protein that is released within the oropharynx that helps in vitamin B12 absorption. And then lastly, taste, as we've already talked about, where saliva is going to help solubilize taste molecules in order for them to enter into the taste buds via the taste pores. The regulation of salivary secretions is via the autonomic nervous system. We have two unconditioned reflexes. So first we have the masticatory salivary reflex, and this is both the major and the minor glands. And for this reflex, we have sensory input from mechanical receptors inside our mouth. These will be located in our muscles of mastication, within actually pain nociceptors within the oral mucosa, and within the periodontal ligament. When these receptors are activated, we will in turn have a reflex, so meaning the message does not go to higher brain function. This reflex will then stimulate salivation. We also have the gustatory salivary reflex, and this is predominantly in the major glands. And this is a sensory signal from taste activated receptors in the taste buds. And then lastly, we have conditioned reflexes. These reflexes are associated with higher brain centers, and this may be associated with things like our past food experience, our emotional state, if we're depressed, and will contribute to salivation. This is a nice little flow diagram of the physiology of neural input with salivary secretion. Some of it you'll be very familiar with. So on the lower left, we have cranial nerve 7 and cranial nerve 9 supplying taste sensation to the tongue. And this sensation, you will recall, is transmitted to the brain stem, where it will synapse in the salivatory nucleus. In turn, the parasympathetic nervous system, so highlighted in blue here, will then have efferent fibers going out to the major glands and will stimulate salivation. We also have another salivary input from cranial nerve 5, so the trigeminal nerve, and the afferent input will be from mechanical receptors that we discussed, or even nociceptors in the oral mucosa and the periodontal ligament. And this will be transmitted also to the brain stem, and in turn will stimulate these same parasympathetic nervous fibers afferent fibers leading out to the salivary glands and stimulating salivation. Now we also have some stimulation of salivation via the sympathetic nervous system as well. And this comes from lower levels in the spinal cord. And in this diagram, we do have some black arrows as well. And this is representing some of our influences from higher levels of the brain on salivation. These higher level brain centers include both the limbic and cortical regions of the brain, can have a profound effect on salivation. A good example of this would be when we have reduced salivation during times of anxiety and great fear. Now, the minor salivary glands are supplied by the parasympathetic nerve fibers in the buccal branch of the mandibular nerve, the lingual nerve, and also in the palatine nerve. Although both branches of the sympathetic nervous system can stimulate salivation, they do so in much different ways. So the parasympathetic branch of the nervous system is our main stimulus for salivation. So this will create an increase in the quantity of saliva that's being produced. We tend to see more watery saliva, so it's definitely targeting the parotid glands. And you will recall that the parasympathetic system works via acetylcholine neurotransmitter, which will bind to muscarinic cholinergic receptors on the acinar cell surfaces. So it will bind to our glandular cells producing the saliva. The parasympathetic nervous system will also act on myoepithelial cells to stimulate contraction and encourage salivary secretion. It will also increase blood flow to the salivary glands. Now, comparatively, the sympathetic branch doesn't stimulate as quite a great increase in flow, but it increases the viscosity of the saliva. The sympathetic branch works via norepinephrine as its transmitter, and these will bind to the alpha adrenergic receptors. And this is a nice summary diagram of the key points that we've just spoken about, with both the parasympathetic and sympathetic nervous system being able to stimulate salivation just via slightly different receptors, with the parasympathetic nervous system being definitely the more major player in salivary secretion. And you can see in this diagram we have certain conditioned foods, nausea, smell can all increase salivation, whereas if we're dehydrated or if we're frightened, if we're planning to go to sleep, we will have decrease in parasympathetic stimulation and thus a decrease in salivation. Salivary dysfunction is not an uncommon problem you're going to encounter in your patient population in dentistry. Patients may have decreased stimulation of salivary reflexes. You might see this in a denture wearer. You might see a problem with the autonomic nervous system. It's very tuned into increased levels of stress and depression. The patient may be on drugs that may affect the receptors that the autonomic nervous system are going to activate to stimulate salivation. There might be a dysfunction with pumps, with the cation pumps affecting salivary osmolality. And you may also see people suffering from autoimmune conditions or have a history of radiation exposure that has resulted in damage to the glandular tissues. The best way to understand the true importance of saliva is to view some of the oral consequences of salivary gland dysfunction. So it can affect denture stability in patients. It can lead to dental caries, development of dental calculus, and thus increased periodontal disease, gingivitis, increased levels of candidiasis or yeast in the mouth, bad breath, so halitosis, dysgeusia, so altered taste, as well as tissue sensitivity. So if we've lost that nice mucin barrier to make our tissues slippery, it can cause some real sensitization of the tissue surfaces. And here, just to finish off the lecture, is a few examples of some of the effects of xerostomia or dry mouth in patients. So on the upper left, you can see a very dry mouth that has obviously had decreased buffering capacity of the saliva, and the patient's been experiencing a fair amount of erosion of the enamel on the occluding surfaces. On the upper right-hand side, we see absolute florid cervical caries secondary to dry mouth. So we've lost the antimicrobial as well as the remineralization capabilities of the saliva. On the lower left-hand side, this is just an example of what once was a salivary gland that has been completely destroyed and replaced by just fibers of scar and collagen secondary to radiation. And on the lower right-hand side is the devastating effects of that marked decrease in salivation in a radiation patient. Thank you very much for your attention, and enjoy the rest of your day.